should probably get started, or you think there will be there?
Okay.
For tomorrow.
Hola. Bueno, buenas tardes a todos. Tenemos el gusto de compartir esta sesión conjunta entre dos sociedades continentales, como son la ISEL y como es la ALEH. La verdad es que como latinoamericanos debemos sentirnos orgullosos de esta posibilidad que se ha ido generando en los últimos años desde nuestra asociación de acercarnos a las demás asociaciones continentales con todo lo que ello implica desde el punto de vista de apertura para cosas tan importantes como son la educación y la investigación conjunta. Como parte del corolario de tamaña hazaña que se ha logrado, agradecemos muchísimo la presencia acá de Tom Carlsen. Tom, como ustedes saben, es secretario general de la ISEL y nos va a dirigir unas palabras desde su lugar. Tom.
Thank you very much. It's a great honor and a great pleasure for me to be here on behalf of the European Association for the Study of the Liver. We have over the last years had, I would say, increasing collaborations with our Latin American sister society. And this takes the form of, for instance, among other activities, also to have joint programming in each other's meetings in order to exchange peculiarities and specialities from both sides and from both societies. I will, without further ado, introduce the first speaker on behalf of ISEL, our EU and Policy Counselor, Helena Cortes Pinto from Portugal, who would introduce two lectures related to NAFLD.
Buenas tardes a todos. I will now speak in English. Dr. Tom Carlsen, Dr. Alejandra. So it is a great pleasure and a great honor for me to start this ALEH-ISEL symposium. And my first talk will be on the CPG NAFLD guidelines and the other on the emerging treatments. So these are my disclosures. These guidelines have been published in 2016 and they were made together with two important European societies, the Society for the Study of Diabetes and the Society for the Study of Obesity. And during this presentation, I will also show some slides from the slide deck that is now in the ISEL website. That's easy for everybody to use and to see. So the first point is the definition of NAFLD. In fact, NAFLD is a spectrum of disease defined by the excessive fat accumulation in more than 5% and needs the exclusion of secondary causes. It can be divided in NAFL, where we have only pure steatosis or steatosis and mild inflammation, and then the full-blown of necroinflammation, that is NASH. That can be non-fibrotic early with F0 or F1, or can be fibrotic F2 to F3, or really cirrhotic fibrosis. In either NASH or cirrhotic NASH can progress to HCC, what is a major worry in this situation. One important point, I said first that we have to exclude other causes such as alcohol. However, both alcohol and obesity can produce this spectrum of lesion from steatosis to steatohepatitis, and both can progress to cirrhosis and HCC. And the difference between the two of them is just based on this quite arbitrary consumption of alcohol of more than 30 grams in males and 20 grams in females to define either as alcoholic or non-alcoholic. However, we have been increasingly seeing a significant overlap of obesity and excessive alcohol consumption in inducing fatty liver disease. And we still have to see how useful is it to keep them separated or have them in a only entity. What's the prevalence of this disease? It is now it is probably the most common liver disorder in the Western countries. It affects about 17 to 46% of adults, and it parallels the prevalence, the increasing prevalence of the metabolic syndrome and its components, which also increase the risk of more advanced disease. However, NAFLD, it's also present in 7% of the normal weight, the lean individuals. According to Yonusi, who was able to gather several studies from different areas of the world, and as you can see here, the median prevalence is about 25% of the population. However, some areas such as Africa have much lower prevalence, and others such as the Middle East, and what is of particular importance for this audience, South America has a very high prevalence of 30%, as was yesterday very well discussed by Dr. Mendes. What probably may have to do not only with the obesity, but also with some genetic predisposing factors. In Europe, ISL has commissioned to the UK Health Forum a large study on the burden of liver disease. And I'm showing you here some data. It has been recently published in the Journal of Hepatology. And what we can see here is that in Europe, NAFLD-NASH represents only a very small proportion of liver-related mortality. I cannot point out, but you can see that there are these very small red bars. So it's really a very small proportion. And this may be due to several factors. One is that the disease is not really identified by medical doctors. The other is that these patients probably die of cardiovascular disease, and so they don't really die of liver disease. And the other is that the codes, the codification of the disease is not done rightly in the OBIT certificates. But if we have a so frequent disease, should we screen for NAFLD, and who should we screen? And in fact, the majority of the scientific societies of the liver have stated that there is no role for screening the general population. There is a very limited value on that, and that is due to the high direct and indirect costs, but also to the low predictive value of the non-invasive tests, the risks associated with liver biopsy, but most of all, probably, is the lack of effective treatments. So the recommendations from the guidelines are that all individuals with steatosis should be screened for features of the metabolic syndrome independent of liver enzymes, and all individuals with persistently abnormal liver enzymes should be screened for NAFLD. And then in high-risk individuals, such as those with type 2 diabetes, age more than 50 years, or the presence of the metabolic syndrome, it is important to find advanced disease and look for it. This has a very good grade of evidence and too as great of recommendation. The assessment of steatosis, it's still the ultrasound, the preferred first-line diagnostic procedure, since it also provides, it's non-expensive and provides additional diagnostic information. However, when the imaging tools are not available or feasible, we can use serum biomarkers, and scores are acceptable alternatives. Mostly in large epidemiological studies, this can be acceptable. A quantitative estimation of the liver fat can only be obtained by magnetic resonance spectroscopy. However, this technique should be used only on clinical studies or clinical trials, since it's in fact very expensive, at least for the moment. And what about pathogenesis? There are two major factors. One is, of course, the lifestyles. And we are very much aware that a Western diet and lifestyle has been associated with weight gain, obesity, and NAFLD. Mostly associated with a high caloric intake, with the excess ingestion of fat, mostly saturated, but also high fructose intake and a sedentary behavior. So the recommendation is that first, healthy lifestyles, in fact, play a role in the development and the progression of NAFLD, and that the assessment of the dietary and physical activity should be part of the comprehensive NAFLD screenings. It has been also recently noted by Zelber Sagi, that has published a lot in this area, that also the consumption of the high consumption of red and processed meat, as well as unhealthy cooking with grilled or broiled techniques, is also associated with NAFLD and with insulin resistance through these different mechanisms. Another important point are the genes. And in fact, several genetic modifiers of NAFLD have been identified. However, only a minority has been robustly validated. And among those, PNPLA3 variant and TM6F2 variant carriers have been associated with a higher liver fat content and with an increased risk of NASH. And what is very interesting is all the different studies have been in agreement in considering these genes as a putative risk. However, at the moment, genotyping may be considered in selected patients and in clinical studies, but is not recommended routinely. What about the diagnosis? Liver biopsy is still essential for the diagnosis of NASH, because clinical, biochemical, or imaging measures cannot really distinguish NASH from steatosis. And NAFL encompasses steatosis plus one of lobular or portal inflammation or ballooning, and NASH requires steatosis and lobular or portal inflammation and ballooning. And NASH score indicates disease severity, although it should not be used for the initial diagnosis. However, it is impossible to do a liver biopsy in 1/4 of the population if we finally find this 1/4 of the population that has NAFLD. What I think it's not probable, but what I mean is that it's not practical to do liver biopsy in the majority of the patients that present us with NAFLD. So we have to use non-invasive assessments. And the non-invasive markers should aim to first identify the risk of NAFLD among individuals with increased metabolic risk in primary care, identify those with a worse prognosis in secondary and tertiary care, as severe NASH, should also be able to monitor disease progression, predict the response to therapeutic intervention, and if we find this kind of methods, we could reduce the need for liver biopsy. And this is why there has been this consortium that was created in Europe, the Litmus, that is a very large consortium from the major centers in Europe that in fact tries to identify non-invasive markers of the disease and has been very well financed by the European Union, and it's a very, very interesting project. But coming back to the non-invasive methods, what makes it easier is that it was found that fibrosis, among the other histological aspects, is the one that in fact has an important prognostic significance. And there were 2 different studies published in 2015 that show this very clearly. This is the study from Angulo, where we see that it is in fact the fibrosis that defines the prognosis independently of the patient having or not having NASH. And the same was found in the Sweden study from Ekstad and collaborators, with a very large follow-up of about 26 years and a good number of patients. And again, it was the fact of having or not having fibrosis that defined the prognosis. And that is somehow good because it's easy to screen for liver fibrosis than for the presence or absence of NASH. And in fact, in this small publication, we have stated that there are very simple and inexpensive methods to screen for liver fibrosis that are the NAFLD fibrosis score and the FIB-4 that are very easy to use in clinical practice and that can define those with a very low risk, those with an intermediate risk, or with a high risk. And then we have more expensive tests, the complex patented tests such as ELF, Fibro test or fibrometer, and the FibroScan that at least in Europe is in a middle price, in a medium price, that can also be very useful to evaluate the degree of fibrosis. However, we have to be careful when using elastography, since it has been found that in NAFLD it has a spectrum bias with cutoffs for the definition of cirrhosis ranging from 10.3 to 22.3 in different studies. So we have to be very careful when using them. So this is a quite busy slide, but I will try to go through it. So if we have patients with evidence, with imaging evidence of fat accumulation, defining them as NAFLD, we really should rule out advanced fibrosis. And by the use of the NAFLD fibrosis score and the FIB-4, we can have either what is in the green bars, that is about 55 to 58% of the patients that have very low scores. And in these patients, we could be quite confident that they are at a very low risk of having significant fibrosis, and we can just consider repeating the tests in 2 years and send them back to the general practitioner. On the opposite side, on the pink bars, we have those that have high values of the NAFLD fibrosis score or of the FIB-4, that correspond to 12 to 15%, those are the ones that are in high risk and we should consider for liver biopsy. And in the middle, in the blue bars, we have the 30% that are in an intermediate stage or that have discrepant results from the FIB-4 and the NAFLD fibrosis score. And in those, we could use other methods, such as the fibro test, the fibrometer, or the elastography. And depending on the results, we could either consider them for liver biopsy or just consider repeating the tests in about 2 years. And what about the natural history of the disease? One of the major problems is the cardiovascular disease. In fact, that's the major cause of death in these patients. And the prevalence and incidence of cardiovascular disease is higher in NAFLD than in the matched controls. And that is mostly driven by the association between NAFLD and the metabolic syndrome components. So cardiovascular disease should be identified in NAFLD regardless of the traditional risk factors. And cardiovascular disease and metabolic risk factors are also reported in adolescents and children with NAFLD. So it's mandatory to screen the cardiovascular system in all individuals with NAFLD because of the potential complications of cardiovascular disease, although we can discuss what would be the best way to do that. That's one meta-analysis that shows that, in fact, the risk of fatal and non-fatal cardiovascular disease associates with more severe NAFLD. So it's not only NAFLD, but more severe NAFLD with a odds ratio of 2.5. Another significant and important complication is HCC. In fact, the cumulative incidence of NAFLD-associated HCC varies according to the study populations, and a large number of NAFLD cases are at risk of HCC, and so it makes quite impossible the surveillance of all these individuals. We know that the PNPLA3 variant is associated with an increased risk. However, and the guidelines state that very clearly, HCC surveillance in NAFLD is not yet considered cost-effective at the present time. And now moving to treatment. So the diet and lifestyle are in fact the mainstay of the treatment and are mandatory in all patients. We know that modest weight loss is already able to reduce liver fat, improve hepatic insulin resistance, and can result in NASH regression. Weight loss of more than 7% associates with histological improvement. So the recommendations are that patients are recommended structured programs aimed at lifestyle changes towards a healthy diet and habitual physical activity. Patients without NASH or fibrosis still need to be counseled for healthy diet and physical activity, although no pharmacotherapy is necessary. And in overweight, obese, and elderly patients, a 7 to 10% weight loss is the target of most of lifestyle interventions and results in improvement of liver enzymes and histology. So this is the comprehensive lifestyle approach. So it's based mostly on energy restriction. The calorie restriction should be 500 to 1,000 per day, targeting again the 7 to 10%. And a long-term maintenance approach should be sought. Patients should avoid the fructose-containing foods and drinks. In what regards the macronutrient composition, it may be not make a big difference to choose diets that are more low fat or low carbohydrate, and it may depend on the preferences of the patient. It's more important to reduce the caloric intake as a whole. Then in what regards daily alcoholic intake, it should be strictly below 30 grams or 20 grams, but in patients that already have cirrhosis, it should be 0. Physical activity should be about 150 to 200 minutes a week, and it should be a mixture of resistance and aerobic exercise to promote musculoskeletal fitness and improve metabolic factors. When nothing is able to reduce weight, we can always have bariatric surgery. And in fact, the group of Philippe Mathurin has very well shown in this presentation in last ILC with a group of 198 patients with biopsy-proven NASH, that bariatric surgery was able to induce the disappearance of NASH in 85%. And what's more interesting is that this is maintained after 5 years. And the same with fibrosis, that was also reduced at 1 year and continued to improve at 5 years. So the guidelines state that it is an option in patients unresponsive to lifestyle changes and pharmacotherapy, reduces weight and metabolic complication, and has stable results in the long term. Moving now to pharmacotherapy, treatment should be indicated in patients with progressive NASH, with early stage NASH with risk of fibrosis progression, active NASH with high necroinflammatory activity. And the aims should be to reduce NASH-related mortality and progression to cirrhosis or HCC, and the resolution of NASH-defining lesions is accepted as a surrogate endpoint. We need to be careful about the safety and tolerability prerequisites. The two drugs that can be recommended is pioglitazone or vitamin E, although both have their problems. In fact, pioglitazone was abandoned in several countries in Europe and has a risk in patients with heart failure. And vitamin E should only be used in patients with NASH and no diabetes. In what regards to the optimal duration of therapy, it is unknown. And in patients with increased ALT at baseline, the treatment should be stopped if there is no reduction of aminotransferases after 6 months of therapy. Finally, statins can be confidently used to reduce LDL cholesterol and prevent cardiovascular risk, having not much of an effect in liver disease. And my final slide to this presentation is that, in fact, at the present time, no medications are approved by either the FDA or the EMA for the treatment of NAFLD NASH, and any drug treatment is off-label. And that moves me to my next presentation that I would now ask if you could put my next presentation, please. Because since we don't really have a good treatment at the present time, there is this great need for new therapies. However, the good news is that we already have a very effective treatment. In fact, this is from Vilar Gomes and Romero Gomes. What is shown here is that in the 10% of patients that are able to achieve a 10% weight loss, we have a NASH resolution of 90%, fibrosis regression of 81%, and steatosis improvement in 100%. However, only in 70% of the patients undergoing this kind of intervention only can get a 5% weight reduction. And with that, the NASH resolution and the fibrosis regression and steatosis improvement is in fact much lower. So although we know that there is something that is effective, we know that in most cases it doesn't work. And so there has been an enormous interest for the pharmaceutical industry to develop new treatments for NASH. And this I assessed 2 days ago in clinicaltrial.gov. What we can see is that there are now 561 clinical trials for non-alcoholic steatohepatitis. But I will not discuss with you all these clinical trials. You can be more restful. I will only focus on some of them. So there are different and several mechanisms of action that are potential targets for new drugs in non-alcoholic steatohepatitis. The major points, sorry I cannot point, are either through the metabolic sign, through the metabolic via, or the anti-inflammatory related targets, or finally the anti-fibrotic drugs. Because through all these mechanisms, we can have ways to resolve or at least to try to resolve the problem. There has also been much discussion about what are the significant endpoints in the NASH clinical trials. And at the present moment, we have 3 important endpoints. It's the improvement of steatosis, the resolution of NASH, and the improvement of fibrosis. And most clinical trials presently are using single treatment modalities. However, combination therapies of multiple drugs to treat NASH are now being developed. Since, as you have seen, there are so many different mechanisms that it makes sense that we can have drugs that simultaneously affect the metabolic pathways or the cell death signaling. So there are different ways in different forms of mechanisms. I will start with the phase 3 drugs. The phase 3 clinical trial studies. And I think these are the 4 most important drugs in clinical trials. So diabetic colic acid, OCA, elafibranor, selonsertib, and senicrivoric. Starting with obeticholic acid, it is an FXR agonist. The farzinoid receptor, the FXR, is a nuclear receptor that acts as a master regulator of bile acid metabolism and signaling. And it was shown to have several very positive effects in reducing inflammation and fibrosis, and also an effect on the carbohydrate metabolism. So clinical studies started, and probably the most important study was the FLINT. That's a phase 2b study. So in the study that has been published in the Lancet in 2015, what was found was that OCA was able to induce an improvement in aminotransferases and an improvement in several histological parameters, but mostly in fibrosis, and that is a very important point. However, it has two major downsides. One is that it has a significant number of patients that develop pruritus, and also it is associated with an increase in the LDL cholesterol, what is a major issue in patients that already have a significant cardiovascular risk. Although, of course, we can use statins, but that is really a major problem. However, coming from this phase 2 study, two phase 3 studies are now ongoing. One is the Regenerate study that is now enrolling patients. It's planned to have 2,500 individuals, all F1 and F3. That's one of the major issues, is that all clinical trials are in fact targeting F1 to F3 patients, at least the majority. However, they also are planning and already start recruiting 500 cirrhotics for the reverse study. And then we have elafibranor. Elafibranor is a PPAR alpha and delta agonist. It regulates multiple pathways that are essential in NASH. It has an effect in decreasing fibrogenesis, but also in decreasing oxidative stress and inflammation. And this has also a decrease in the atherogenic lipid profile. And so it could simultaneously be beneficial in what relates to cardiovascular risk. And in fact, there was a first phase 2 study, the Golden 505 study, where it showed a significant better reversal of NASH only in a post-hoc analysis. In fact, in the intention to treat analysis that was first planned, it did not reach statistical significance. However, a post-hoc analysis on the group of patients with NASH more than 4 and using slightly different endpoints, it showed a benefit in the dose of 120 milligrams a day in the reversal of NASH without fibrosis worsening. And so coming from this study, it is now going on to resolve it. That's elafibranor versus placebo. It's also a phase 3 clinical trial, planning to have 2,000 patients, again with a NASH score more than 4, and targeting F1 to F3 patients. It's being done in 20 countries in almost all continents: Europe, North and South America, Asia, Africa, and Australia. And there are expected results from an interim analysis. Also, we've noted that recently, in June 2018, a GenFit newsletter has stated that the administration of elafibranor prevented liver tumor development in NAFLD-NASH animal models of disease, what could be a good thing. And elafibranor also showed direct cytostatic properties in a large selection of human tumor cell lines. The other drug is selonsertib. It is an inhibitor of caspases, ASK1 inhibitor. It inhibits apoptosis, and it showed to be effective in improving fibrosis. In this study, in fact, it was shown that selonsertib was able to improve significantly more fibrosis than simtuzumab, that was then shown to be not effective at all. So it was used mostly as a placebo. It was considered as a placebo. So it was effective. And from that, Gilead developed 2 other studies, the STELLAR-3 and the STELLAR-4. The STELLAR-3 from non-cirrhotic and the STELLAR-4 for cirrhotic patients. The STELLAR-3 enrolled 800 patients with NASH with bridging fibrosis, and the STELLAR-4 883 patients with NASH-compensated cirrhosis. It is a 48-week trial, and the primary endpoint is 1 point decrease in fibrosis stage without worsening of NASH, ballooning, or inflammation. The study's 5-year outcome is the reduction in progression to cirrhosis in the STELLAR-3, and of course in the STELLAR-4, the reduction of hepatic decompensation or hepatocellular carcinoma, transplantation, or death. So this already stopped the recruitment, but the study is ongoing. Finally, in this phase 3 studies, we have the CENI-CRIVI-ROC. It is a CCR2 and CCR5 inhibitor. There was the first study that is already published in hepatology, but last spring, during ILC, Vlad Razio presented the 2 years results. What they could see in the 2 years is that there was an improvement in fibrosis by more than 2 stages with no worsening of NASH. So if they looked only at the improvement of fibrosis in 1 stage, the difference was not really, there was no difference. And even here, the difference is not really significant, but it shows an important trend. And so the study is going on. And it's planned now, the Aurora study, that is a phase 3 study with 2,000 patients, again in patients with NASH with F2 and F3, and the primary outcome is the improvement of fibrosis without worsening of NASH. In the phase 2 studies, we have an enormous number of studies. I could not discuss with you all these studies, so I have chosen 3 of these that seem to me to be more promising. The first is liraglutide. Liraglutide is a GLP-1 agonist. It was studied in a small study, the LEAN study, that was published by Armstrong in The Lancet in 2016. And what it shows, so the GLP-1 agonism is an incretin mimetism that acts as an agonist of GLP-1 receptor. It has been used in type 2 diabetes since 2009. Here it showed a significant histological improvement of steatosis and NASH reversion in patients with NASH. And also, simultaneously, there was a decrease in the aminotransferases. The other promising drug is NGM282. It is a non-tumorogenic variant of the fibroblast growth factor 19 that modulates bile acid synthesis. It has been published now in The Lancet by Harrison that it associated with a significantly high reduction in liver fat in the treated arm. It's interesting that this study also used data from MRI PDFF, and the results were very, there was a very good correlation. So I think this could be, in fact, a promising drug. The other drug that was presented again in ILC in April is the MGL3196. It is a THR-beta agonist, and it was shown to significantly decrease hepatic fat in NASH patients at 12 weeks, decreasing also LDL cholesterol and aminotransferases. As you can see here, the effect in fat reduction is quite impressive, and also it was shown that it has no effect on the thyroid function or thyroid hormone levels. These are the other studies. So there are several FXR agonists, non-bile acid FXR agonists that are now undergoing these phase 2 studies, but I will not describe them in details. There's another drug that is not so much talked about, that's Carbolife. Carbolife, it's a very interesting and different drug. It's an oral nanoporous carbon that is able to put endotoxin inside it, so reduce endotoxin in the intestine, and it shows considerable promise as an oral non-absorbable intervention strategy. There's also a consortium in Europe, and we are about to start a clinical trial not only in cirrhotic patients, but also in patients with NASH, non-cirrhotic, but it's through a very different and interesting mechanism. I will show you also this slide from the Kahneman manuscript on the Journal of Hepatology that summarizes most of what I said here about the emergent treatments. As you can see here, these are not comparisons head-to-head, but so there are very different levels of improvement with the different drugs in what relates to the improvement in hepatic steatosis, or the resolution of NASH, or the improvement of fibrosis. However, if you look on the improvement of fibrosis, that's probably one of the most important endpoints. Only for OCA and for Senicrivoric, there was seen some significant improvement in fibrosis. But if you compare this with the effect of the weight loss and the lifestyle interventions, these are much worse results than those of the interventions. So I'm moving to the end, and my take-home messages are that we now have a very large number of promising phase 2 and 3 clinical trials that are ongoing, and results are eagerly attended and expected. However, there are some major issues regarding these clinical trials. One is that there has been difficulties in enrolling patients or in finding patients to enroll. And this is probably because there are difficulties in identifying patients. And although we may say that 1/4 of the population has NAFLD, this is in the epidemiological studies. It's not that these patients present in clinical practice. But then there's also a great difficulty in stratifying risk to identify the patients that really benefit from drug treatment. And I can tell you from my experience that from a large universe of patients with NAFLD, we then come up with a small percentage of patients that really would benefit from treatment or would have the criteria to be enrolled in these clinical trials. So this is a major challenge. And the other challenge is that for the time being, the majority of these trials use multiple liver biopsies. Either Regenerate or Resolve, it have at least 3 liver biopsies. And so patients are not usually very happy with that idea. But hopefully that will change in the future. We will find good and reliable non-invasive methods to be able to do these clinical studies. However, even if very effective drugs are to be found and confirmed, it will be still difficult to define the treatment time. Are we going to treat these patients forever, as we do with diabetics or hypertensive patients? Because, of course, it will tend to recur if the risk factors remain. And so what I think would be really important is the political measures that would be able to revert the epidemics of obesity all over the world. Thank you very much.
Thank you very much, Helena, for two lectures providing a very comprehensive overview of the NAFLD field. So, are there questions from the audience? There's one question there. The microphone to the right.
Thank
Please.
you, Elena, for these presentations. The question is there, which is your ideal patient to indicate bariatric surgery within the NASH frame? And related to that, do you indicate this treatment in patients with already established cirrhosis? And do you discriminate with early or late compensated cirrhosis?
Thank you very much for this question. It's very important. I only indicate, and I think that the literature is with me, I only indicate bariatric surgery in patients that have morbid obesity and have other reasons for doing bariatric surgery, not specifically for the treatment of NASH. In what regards cirrhotic patients, if a patient has any evidence of portal hypertension, it's completely contraindicated. If the patient is found to have portal hypertension, for instance, in an endoscopy, or even during surgery, it should be aborted because the risk is very great. In very well compensated child A cirrhotics, I think it's more controversial, but I would be very careful because I think it's very risky to undergo bariatric surgery in this circumstance. Of course, we could discuss, there are some groups, but there are very, very few data from the literature on bariatric surgery on well-compensated cirrhotics. But if they are not compensated, completely.
¿Tenemos lugar para una pregunta más?
Hi, yes. So there's a very large population of NASH-NAFLD, and now we have increasing techniques of endoscopy that help for weight loss. So recently the FDA approved balloons, and now there's an endoscopic sleeve. So do you think those therapies might be able to help those patients that only have to lose about 10% of their body weight? We don't need 30% of their body weight as with bariatric surgery. So maybe we could help these NAFLD NASH patients, especially the NASH patients, with maybe intragastric balloons or endoscopic therapies for weight loss. What do you think about that? It might even be interesting to do research protocols on these patients.
Thank you very much again for this question. In fact, there is not much data in the literature regarding this defect on NAFLD of these techniques, of these endoscopic techniques for reducing weight. Of course, it is in most cases it could be a good idea, although with balloons, I'm always a little bit afraid because balloons have this short time where it works, but then the patient takes the balloon and often recuperates his weight. At least that's my experience. What's good in the bariatric surgery, it's that it's quite stable, the way that people lose weight and stay in a less weight scale. But and all the measures that are very temporary, unless you believe that you could change the behavior of the patient through these temporary measures. But I completely agree that more protocols of study should be initiated in order to demonstrate if it is effective or not, because for the time being, we don't have so many.
Muchísimas gracias, Elena. Invitamos al doctor Tom Carlsen a avanzar con la revisión de las guías de práctica clínica en enfermedades autoinmunes y colestásicas. El doctor Tom Carlsen, más allá de ser secretario general de la Asociación Europea, es además especialista clínico en medicina interna y gastroenterología, jefe de la División de Investigación en Cirugía, Medicina Inflamatoria y Trasplante de la Universidad de Oslo, líder del Centro de Investigación Noruega de colangitis esclerosante en el Departamento de Medicina, Trasplante e Investigación, secretario y cofundador del Grupo de Estudio Internacional de Colangitis Esclerosante y coordinador del Registro Nórdico de Trasplante de Hígado, más allá de ser una persona con una visión absolutamente inclusiva para nuestros países. Así que bueno, Tom, más allá del orgullo de tenerte, gracias por todo.
Thank you very much. Again, it's an honor and a pleasure to be here. The first lecture, two very different lectures this time, will be related to the management and primarily the medical management of autoimmune liver and bile duct diseases. This will also be the topic of a symposium tomorrow. I mean, these are overlapping entities, PBC, autoimmune hepatitis, PSC. You also could consider autoimmune pancreatitis in this domain. However, this is where I will focus today's presentation. This is covered at the moment in 3 different clinical practice guidelines from EASL. There is one on cholestatic liver disease, which is getting old. There is a new PSC guideline in development. We have recently published autoimmune hepatitis and PBC CPGs, and this is where I will be taking most of the data from. When we're talking about treatment in these diseases, it's a complex measure, similar to the considerations that you have for NAFLD. It's very unlike hepatitis C, where you have an SVR, and that's when you have your treatment efficacy. Here you're talking about compound endpoints, biochemical, serological, histological, ultimately transplant-free survival. You need to take care of patients, their experiences, side effects, particularly considering that these are chronic conditions requiring long-term treatment over decades. The databases of the recommendations that can be provided are very scarce. Altogether, there are less than 75 randomized clinical trials in autoimmune hepatitis, PBC, and PSC, comparing, for instance, with more than 1,000 trials in IBD. If you look at the challenges or the challenging patients, in autoimmune hepatitis, there is a fraction, 10–20%, PBC slightly higher. In PSC, I would be actually claiming that most of the patients are quite tough, particularly when it comes to the medical management of the patients. I will start with autoimmune hepatitis. Again, there will be a lecture tomorrow, so I will not go too much into diagnostics and the diagnostic considerations. First slide here basically showing that when you have a patient with autoimmune hepatitis, you treat. There are a few exceptions, very mild disease, biopsy-wise, biochemical-wise, old patients, contraindications, etc. But the normal rule is that the patients should be treated. Even with cirrhosis. Cirrhosis as presentation is a common finding occurring in 1/3 of the adults, even half of the children, and they do respond somewhat slower. And I would say that the only cases where you should be considering cirrhosis as a contraindication, or at least be possibly refraining from treatment, is advanced cirrhosis, decompensated cirrhosis, depending on the histological activity. So, good response, the responders. The problem is that the measures that we use for determining a good treatment response, which would be the transaminases and immunoglobulins typically, do not show the full picture. Data is around demonstrating that there are, even in the circumstance of normal biochemical parameters, a significant histological activity which impacts on prognosis. And this is important when you're reflecting upon the potential of treatment withdrawal and the management of these patients. It is normally considered useful to consider a trial of steroid withdrawal. The problem in that context is that what I showed you already, the biochemical parameters do not show you the full pictures. And at least in our hands, prior to considering this, we would seriously consider a liver biopsy before going into this avenue. Problem is, of course, the patients mostly recur, and as you can see on the top graph here, the more frequent relapses, or the more relapses you have, the more likely you are to go into a progressive disease requiring transplantation in due time. And in the end, if there is a treatment withdrawal attempt, there is a relapse, the recommendation from EASL is that lifelong immunosuppression is actually advisable, and this is on this compound basis. So, what about difficult to treat? There would be two avenues into this difficulty. The one is the intolerant patients, the other is the incomplete response. There are different considerations for each of these groups, and I think personally this overview here from the MMF data from Hennes illustrates that, where you can see on the left side that in the cases where you have tolerance issues, the remission rates are actually quite high. However, if you already are in a situation of non-response, even going into a second-line avenue will not necessarily be successful. And whatever you do in this territory of second-line therapy, it's off-label, it's not really evidence-based. They are based on case series, single case reports. And there was actually this survey from the International Autoimmune Hepatitis Group, which actually illustrates a little bit, I would say, the prescription patterns of second-line therapies. MMF currently being the most popular ones, tacrolimus, which we're also using at our center, cyclosporin, and then you have the more experimental therapies with biologics, infliximab, rituximab, as also showing in case series responders. However, this is really a specialist territory, and I would advise that once you're moving into this landscape, the patients are referred to specialist management who would have experience managing these types of drugs in the patients. So what about PBC and PSC? Standard of care in PBC, of course, ursodeoxycholic acid. Of course, I would say, based on EASL guidelines, ASLD guidelines, and the widespread prescriptions. Of course, there are some contrasting data in the literature. Cochrane would not necessarily agree with us. There is response heterogeneity, and there's clearly some stratification as to responders and non-responders. Actually, this is now being, quite heavily elaborated in a numerous series, named typically from the center providing the data. And you can see here that there is actually a considerable fraction, 30%, 40% of the PBC patients that do have an insufficient response in PBC, highlighting the need for second-line therapies, some of which I will illustrate later in this talk, and some of which I will elaborate further in the presentation tomorrow. In PSC, the situation is more challenging. This is the largest clinical trial on ursodeoxycholic acid in PSC. It's the Nordic trial, and actually it failed to show significant efficacy of UDCA in patients with PSC when it comes to endpoints like liver transplantation and death. Then came the Keith Linder trial in 2009, actually showing that if you prescribe high doses of UDCA, 28, 30 milligrams per kilograms per day, actually there is an increase in clinical endpoints in the study population. This actually led to, I would say, a big debate, conflicting situation, actually without any recommendation at all, currently being feasible. EASL is a little bit more positive than the ASLD guidelines. And if you look at the prescription data throughout the world, this is probably the best summary that you can give on the current situation when it comes to UDCA prescription in PSC. Here you can see different time periods downwards, and you can see different regions. And what you would see from this is that actually this high-dose UDCA trial in 2009 led to a quite remarkable increase in the green fraction here, which is no UDCA, particularly in North America, but also in Northern Europe, Western Europe, where actually there has been little UDCA prescription for quite some time. In Southern Europe, Central Europe, there is more UDCA prescription, and I would say that where this landscape probably currently stands is that you would, in many centers, give a trial period of 6 months of UDCA. If there is a biochemical response, you continue. If there is no biochemical response, you take the patients off. Actually, in Oslo, we do not really use much UDCA, which is also, I would say, a reasonable strategy given the current data situation. When it comes to second-line therapies for PBC, we already heard about OCA, obeticholic acid, which is a derivative of quinodeoxycholic acid. I will talk more about the regulatory path which led to the approval of OCA, actually fundamentally based on this publication which came in 2016, which many of you would be familiar with, showing an effect on surrogate markers of PBC progression as determined by this cutoff of 1.67 times the upper limit of normal for alkaline phosphatase. So this was actually quite a breakthrough, I would say. It's the first second-in-line drug that we had for PBC. So it's currently on label in many European countries. It's quite expensive, that is to say. And there is this problem of pruritus, which is occurring in a significant number of patients. You can see the numbers here, 50, 60, even 70% of the patients experience an increased pruritus, somehow hampering the enthusiasm of the drug. Then came, based on a number of series on bezafibrate signals, primarily from Japan, I would say. The Japanese has been prescribing bezafibrates in PBC for a long, long time. And based on the signals that were seen there, we saw now the BES-URSO trial led from Paris, which is a multi-center clinical, placebo-controlled clinical trial on bezafibrate in PBC. Where actually you see similar effects, actually even more pronounced effects as you do for OCA on PBC, however, without this increase in pruritus that you experience with OCA. So I would say that the second-line therapy landscape for PBC at the moment is residing somewhat with the on-label situation for OCA, and then you have the off-label situation for bezafibrate. Bezafibrate cannot be prescribed on-label, to my knowledge, anywhere as of yet. We're currently working on a revision of the clinical practice guidelines in PBC from EASL, and hopefully this situation will evolve. And there are other drugs in the pipeline which we will discuss further in the presentation tomorrow. For PSC, second-line therapy currently is, I would say, almost an irrelevant discussion. We do not really have any first-line therapy. We're questioning the utility of URSO. So I would say in PSC we are still really at the endoscopic and the surgical level with our therapies. There is only one trial that I wanted to highlight in the presentation here today, which is the DIL stent trial, showing in this figure here that the utility of short-term stenting versus balloon dilatation, a balloon dilatation with stenting, without stenting, actually has the same impact on disease progression in PSC. However, what was observed in this trial is that the patients who had short-term stenting had a much higher frequency of adverse events, pancreatitis, cholangitis, as expected possibly, leading currently to a drift, I would say, in procedures towards balloon dilatation without stenting in many centers throughout Europe. The other data that I wanted to highlight in PSC is really this debate regarding antibiotics. Many of you would probably be approached by patients having read about vancomycin in particular. This is also prevalent in pediatric patient populations where parents come and would like to have their children onto vancomycin based on, I would say, pilot data, small uncontrolled trials. Showing a signal. And as I will also elaborate in the next talk, I don't think we have any reason whatsoever into putting our patients with PSC onto long-term antibiotics. This should be considered proof of concept that actually the gut bacteria are important for the disease pathogenesis. However, from there on to actually using this knowledge in providing treatment to the patients, there is a long way to go. So the final slide of my first presentation is actually related to, I would say, an interesting development that we've seen, much driven from the patient societies. Because of course, what I haven't touched upon today, and which we will elaborate also in the session tomorrow, is the symptomatic treatment. You have issues of pruritus, you have issues of fatigue, you have bone disease, you have other aspects related to the diseases. And what we have done for the first time with the PBC guidelines is actually to have a patient version of the clinical practice guidelines. And I would actually encourage you to read this guideline. It's quite interesting reading because it's a flip coin of what we're normally used to see, where actually it's telling the patients why they are experiencing what they're experiencing, what their doctor is actually supposed to be doing in the various situations. For instance, here in chapter 8, in relation to their symptoms. And I think this is also something which is crucial, again, for these diseases where you have long-term treatment, long-term management, questionable efficacy, questionable evidence base for the management that we are providing, that we're actually trying to keep an emphasis on what the patient tells us. So this is the summary slide of the first presentation. We have a very poor or very limited knowledge base, few proper randomized controlled trials. There are common difficulties both in PBC and PSC, autoimmune hepatitis. There is this difficult to treat subpopulation. You have the standards of care in PBC with UDCA. In PSC, questionable. It's still widely prescribed. Remember the symptomatic treatment and the patients, and unfortunately, particularly for PSC, endoscopy and liver transplantation remain key tools in the management. So thank you very much for your attention.
Thank you very much, Tom. Tenemos tiempo para un par de preguntas. ¿Alguien quiere preguntar algo? I'll do one question in the meantime. Do you feel comfortable about most trials evaluating drugs for PBC just basing on surrogate markers and no histology?
No, I think this is currently a big debate in the field. I would say that the basis of using alkaline phosphatase is better in PBC than in PSC. However, what we've seen is that there is a drift, even in the regulatory authorities, towards accepting alkaline phosphatase as a good surrogate markers, both in PBC and at the moment also in PSC. I would seriously question that, particularly in PSC. I would say that the good discussion that we should have regarding surrogate endpoints for clinical trials is how would you measure the efficacy if you were not allowed to use alkaline phosphatase? And this question is very hard to ask, as you would know. So I'm skeptical, but I'm less skeptical in PBC than in PSC. Yeah.
¿Alguna pregunta más? Si no, avanzamos con la siguiente presentación. La siguiente presentación apunta a definir dónde está centralizada la investigación en hepatología hoy, la tendencia que existe hacia concentrarse en el eje hígado-intestino.
Yes, and it looks like I will give the next presentation in Spanish, which is not true. I will stay with English. Coming from a disease, which some of you would be aware, PSC is my primary area of research. You have this situation of a bowel inflammation, a bowel disease, and a liver disease. Of course, the relationship between the bowel and the liver has been an area of great interest for me and my group. This is, I would say, a key observation that has emerged in my reading of this system. The gut-liver axis is a bidirectional system. You have the situation where a number of factors are really going in this gut-liver direction. You have nutrients, microbial components, xenobiotics, drugs, bile acids, immune cells, etc. However, you also have a lot of factors going the other way around. Again, bile acids, you have immunoglobulins, including immunoglobulin A, you have various signaling molecules. And this bidirectional system, and that's a crucial point, is under the influence of the external environment, oral exposures coming into the gut. In this system, of course, there are a lot of factors that we can discuss. There are signaling components. We already heard about FGF19, the FGF19 FXR signaling axis. There are immunological mechanisms, for instance, gut homing of lymphocytes, which occurs from the gut to the liver. However, what I will focus and center this discussion around is the microbiome or the microflora of the gut. As you can see to the right here, there is a number of cells, bacterial cells, equaling the number of cells in the human body residing in the gut. Some people have claimed it's 10 times more. Actually, it seems to be quite similar as to the most recent calculations. As you will also see that the biggest compartment of this bacterial system actually resides in the colon with a decreasing number of microbes the more proximal you go. However, as we are all as gastroenterologists aware, even the low prevalence bacteria that we see in the proximal parts of the GI tracts, for instance Helicobacter, are not irrelevant. And also there is at the moment an increasing interest in the relevance for endocrine signaling, for instance, of the bacterial flora of the duodenum and the jejunum. I will, however, today focus mostly on the colonic flora. The reason why this has sort of boomed is, I would say, a technical one. We've had better sequencing machines in the middle to at the bottom, and we have better computers. And because of this, we're currently able to detect a large number of bacterial species that we were never really able to determine using culture methods. However, as shown to the left here, even with these quite sophisticated sequencing methods, we're still doing quite crude science. For instance, with the 16S-based methods, we are typically talking about families of bacteria, genus of bacteria, and I mean, comparing with the situation for Homo sapiens, this is not really a very sophisticated conversation. Going deeper into the system, this requires more data and more methods. I would say that a key observation from the studies of the gut microbiome is the importance of diversity. I would say it's almost a universal observation in any disease states that there is a reduced diversity. We have two different measures of diversity, alpha diversity, beta diversity. You can, the one is within the individual and the other is between individuals. And I would say that a simplified illustration of what we're talking about here would be comparisons of the industrial forests of Sweden and Norway, where you have planted trees looking quite similar compared to the rainforest that you have in Latin America. Also, what does this mean? If you go deeper, you don't only look at bacteria, but you look at their gene content. This is the current approach that we are taking into the field. We're doing full metagenome sequencing. We're characterizing the gene content of the gut. We're looking at the functional equivalence of this. For instance, we find in our patients that there is a reduced fermentation to butyrate, a short short-chain fatty acid. This we can actually confirm then further on with metabolomics, giving you an illustration of the current working modes of this field. Importantly also, the gut microflora is more than bacteria. We're typically talking about bacteria. There are other compartments. There is a virus component, and there's also a fungal component. And the relevance of these compartments is shown here from alcoholic liver disease, where you can see this transition from a healthy mycobiome, fungal situation in controls, progressively changing as you go from early stages of alcoholic liver disease into advanced liver disease. So what does this mean? I think that's the fundamental discussion we're having at the moment, those of us working in this field. There are lots of data around now. I mean, I'm showing you here, we already heard about NAFLD. There are data from NAFLD showing how you actually can differentiate even the fibrosis stages in NAFLD, that there are changes in the microbiome which occurs throughout the progression of the disease. Also in the disease we are working on in Oslo, primary sclerosing cholangitis, there are significant changes in the gut microbiome. We can even use it for diagnostics, as you can see here from the ROC curves. But what is this telling us? Is it a cause of the disease? Is it because of these changes that these diseases develop? Or is this simply a consequence of the disease? Probably both. Currently, the establishing of the causality here is quite complex. And that's why I wanted to show to you today a way of reasoning when you're discussing these microbiome shifts that probably simplifies the thinking a little bit. And many of these avenues that I'm illustrating for you are probable. As you can see here, for the green versus the yellow diagram, I already told you diversity goes down. It's characteristic for any disease state. And there is a shift. So it's different and it's less rich. Then, within this less rich microbiome, there are a variety of possible factors involving in disease. If you look at the immunological aspects of this, one classical to the left interpretation is that in this microbiome you have increased or exaggerated release of microbial components, LPS for instance, which is triggering the innate immune system. However, there is also the possibility, as shown in the middle and to the right, that there are adaptive immune compartments which are actually interacting with the gut microflora. Examples from this immunobiological aspects of the microbiome is widespread in the literature, also relating to liver diseases. Here is from alcohol-related liver disease, where this systemic inflammatory component, which you observe in disease, seems to be related to barrier dysfunctions of the gut and a release of LPS into the circulation. This is actually also seen in cirrhosis, where you see here in the green curve this enhanced systemic endotoxemia, again a function of this reduced diversity, also paralleling metabolic changes. When it comes to the immunogenicity, there is also the adaptive compartment that should be considered. This is a very important landmark study back in 2014 from Richard Flavel's group, showing that if you stain, and if you follow column A to the left, the microbes using IgA, you would actually see that in patients with inflammatory bowel disease, this IgA positive immunobiome is very different from the rest of the microbiome and actually can be used in mouse models to trigger inflammatory bowel disease. So you have a transferable immunogenic compartment of the microbiome. There is also, as a function of all this, a surge in the interest of unconventional T cells, NKT cells, mate cells reflecting specificities going toward vitamin B metabolites, as you can see here, different specificities relating to different species, and I would say this is a territory which is currently opening up. That much for the immunological aspects. So also very clearly this 1.2, 1.5 kilograms of bacteria that we possess in our intestinal system is also a gigantic metabolic machine. It's involving in de novo synthesis of a variety of compounds. We all know vitamin K, and also in a co-metabolism function versus the host, for instance, in bile acid metabolism. The involvement of microbial enzymes in the bile acid metabolism is known for decades, where you have a variety of enzymatic changes, most classically the production of the secondary bile acids. This is also influencing these signaling pathways that we already talked about. It's influencing the FXR and the FGF15 or 19 in humans, that would be signaling pathways. Here showing how mice grown in a germ-free environment have a almost absent activity in this signaling system compared to conventionally raised mice, due to differences in the bile acid pool, again as a function of the altered bacterial compartment. You lack basically this metabolic machine which is necessary to give you a healthy physiology. This is probably also relevant to diseases. This is a growing field of interest. Hepatocellular carcinoma, there is data, Japanese data, showing how the involvement of the microbiome in the transformation of bile acids is involved in the pathogenesis of hepatocellular carcinoma. So we talked about the immunobiome, the endobiome. So what about the exterior? We all know from our clinical practice about drugs being transformed by the microbiome. Also microbial constituents go through this compartment. Actually, if you look at it coming from the exterior, you actually have this first compartment, the bacterial compartment, and then you have the second compartment of the gut, of the liver. So there is a pre-portal phase of metabolism that affects everything we're exposed to, the exposome, and ultimately influencing a wide range of human physiology. There is much data into this territory. I will only mention the TMAO as an example. This is a derivative which is coming from L-carnitine, prevalent in red meat. Further transformed from TMA into TMAO in the liver, and probably, as illustrated in this New England Journal of Medicine paper from 2013, in the pathogenesis of atherosclerosis, showing how the gut activity of the gut-liver interior axis actually is relevant to the pathophysiology of human disease states, and also in normal physiology. I could give you dozens of examples of similar phenomena. So how is this relevant to therapy? Of course, there is this liver-centric possibility that you actually go for the liver. However, there is this intriguing feature here that you actually have a big compartment which is very approachable by therapeutic manipulation. For the liver-centric approaches, we already heard about FXR agonists. There are also clinical trials in PSC targeting MADCAM1. So you could, of course, go for the liver. However, if you talk about the gut, the story becomes much, much more stimulating and interesting. And I would only mention here basically two categories of therapies. Antibiotics is the first one. Quite devastating if you look at it from the ecological perspective. You basically kill a lot of bugs. There is some recovery, but the recovery is somewhat distorted. As I told you already for PSC, the way that I perceive antibiotics into this gut-liver axis is really that it's a proof of concept. It shows you that the gut-liver axis is important because when you change it, the disease state changes slightly, but it's not what you're going to use for therapy. When you're talking about therapy, you're talking about much, much more subtle manipulation of the bacterial flora. One quite interesting avenue, of course, is the fecal transplantation, where you have basically the transposition of a healthy microbiome into diseased patients. This we've used for years for the Clostridium, the refractory Clostridium difficile colitis. There are also now data out for primary utility of this treatment, and it seems to be working. This is also coming into hepatology. This is data on hepatic encephalopathy, the study by Bajai, published last year, showing that there is a more rapid recovery in patients with fecal transplantations compared to placebo controls. Then there is the story about probiotics, and I think I wanted to highlight here 2 Cell papers which just appeared 1 month ago, which actually questions heavily this concept of, I would almost tend to call it yogurt transplantation. The first trial, or the first study, big papers, both of them, actually illustrating how, following a course of antibiotics, the upper part of the figure, if you give probiotics here, you actually prolong and you distort the recovery following an antibiotic course. So it's actually, contrary to belief, counter beneficial compared to spontaneous recovery and again fecal transplantation. The other story to the right is also interesting because it's leading us probably where this fielding heading, where you actually observe that following administration of probiotics, it's not like this is a one-size-fits-all. There is a subpopulation of patients who seem, or individuals that seems to allow for the growth of these species, that there is a niche for these species. And I think this is where we will see the field is moving for the coming years. And I will illustrate that by showing you 2 different concepts. The one to the left is, what do you want to accomplish? What do you want to do? Here, for instance, you want to have more Treg activity to prevent the development of IBD. So, and the other part is, so, okay, which of the bacteria that we actually provide you are likely to survive, given your microenvironment, your forest, your jungle, whatever? What do you put in there, and what is the likelihood that these bacteria thrive? And if you look at this again to the left, you can see that depending on what bacterial cocktails you're using, you're accomplishing different things. And here they actually developed this 70 species cocktail, which actually had a particularly strong capacity for inducing Tregs in the patients. So they accomplished what they wanted. The summary figure of the cell metabolism paper on the right shows the other phenomenon that depending on the host and the donor and the host or the recipient characteristics, microbial characteristics, you would actually be able to identify which is the perfect match. And this we do in organ transplantation, right? We have our HLA matching for kidney transplantation, blood group matching for liver transplantation, and this is also where the field of fecal transplantation is going. And of course, diet. I mean, this Helena already talked about in NAFLD is clearly going to be a big actor in this space. As you can see to the left, depending on the diet that we eat, these are different types of diet. I will not go into the specificity of these diets, but clearly depending on the type of diet that you have different forests in your gut. And depending on that, you have hugely variable metabolic responses, to even down to the minute nutrient compositions. You can see here, even for if you look at blood glucose response to banana and cookies here to the right, 2 different individuals, completely different profiles, again resulting from their microbial compartment. And this is where probably the dietary field is moving, where you have this complex consideration of the gut microbiome, the diet that you would be eating, genetics probably coming into play, leading to personalized dietary recommendations that would actually optimize the metabolic consequences of what we eat. That this is relevant also for liver disease is clear. This is just one study, again from the Bajaj group, showing how the tendency to move into decompensation actually seems to rely on the dietary patterns of individuals. To the left, US-based diet, left or the right, a Mediterranean-based diet, high fraction of fermented milk, vegetables, etc., much less hospitalizations, etc. And I think that with time, the tools that we have now illustrated is going to help us in guiding the manipulation of these systems for our patients. This is my group in Oslo. It's a little bit colder there than here. There are the two key postdocs in my group that are actually responsible for much of the work that I've shared with you today. This is the bigger international PSC study group, and these are my take-home messages. Think about the gut-liver axis as a bidirectional system. It's linked with the environment. There are new genome technologies. It's making the field bloom. Try to conceptualize the findings, thinking about metabolism, the endobiome, the immunological aspects, the immunobiome, the xenobiome. Then the thinking of this very complex space becomes feasible. And I think if you look at it from a therapeutic perspective, these gut-centric treatment approaches, it's moving towards individualization. And I think we will get there, and we will see a lot of exciting developments in the years to come. Thank you very much. Yeah.
Thank you very much, Tom, for that exciting talk. Si alguien quiere hacer una pregunta, es el momento. Mientras tanto, el doctor Mendizábal y el doctor Gadano los invitamos a ir subiendo para el próximo caso clínico. ¿No hay preguntas? Thank you, Tom. El doctor Mendizábal es coordinador del grupo de investigadores jóvenes de la ALEH y el doctor Gadano ya lo conocemos bien. Manuel.
Bueno, muchas gracias a los organizadores por la invitación y a ustedes por estar acá y no en otros lugares del complejo. La intención de este caso clínico es presentar o tratar de resumir un poco los conceptos que presentó la doctora Elena Cortés y vamos a ir moviéndonos un poquito más rápido por cuestiones de tiempo. El caso clínico comienza con un varón de 48 años de edad que consulta por elevación de transaminasas, presenta como antecedentes ingesta de alcohol leve, no fumador, actividad física 2 veces por semana, hipertensión arterial, resistencia a la insulina y su medicación para esa hipertensión es enalapril. El peso del paciente es de 95 kilos, una talla de unos 75 centímetros, lo que nos da un índice de masa corporal de 31. La tensión arterial habitual que maneja es 135/85 y en el examen físico, como único dato positivo, presentaba una hepatomegalia no dolorosa 2 centímetros por debajo del reborde costal y en la ecografía abdominal podíamos ver un hígado de forma y tamaño conservado, con ecogenicidad aumentada y sin lesiones focales. Entonces, en este paciente de 48 años, hipertenso, con esteatosis en su ecografía y resistencia a la insulina, en el laboratorio como datos positivos podíamos encontrar, como ven resaltado en negrita, una ALT por 3, una AST por 1,5, FAL normal, GGT elevada 103. Cuando vamos al aspecto metabólico, como datos positivos, una insulina de 17, un OMA de 4, colesterol total de 190, pero con un HDL bajo de 38 y triglicéridos de 145. El resto de los laboratorios, el nivel serológico y de autoinmunidad eran negativos. Entonces la primera pregunta, Adrián, en este señor de 48 años con hipertensión, esteatosis y resistencia, ¿cómo confirmaríamos el diagnóstico de hígado graso no alcohólico? ¿Con una biopsia hepática, con una elastografía, con métodos serológicos no invasivos, como estuvimos viendo recientemente, o no hace falta, ya con la información que contamos, te parece que es suficiente?
Bueno, es un caso muy ilustrativo. y teniendo en cuenta la primera presentación de la doctora Cortés Pinto, me parece que es importante, si bien es un paciente que evidentemente tiene enfermedad por hígado graso no alcohólico, es indudable que tiene esteatosis, demostrada ecográficamente y tiene varios factores: resistencia a la insulina, sobrepeso, tiene transaminasas elevadas por 2, por 3. Entonces uno podría decir que y no tiene otras enfermedades hepáticas documentadas. Podría decir que tiene enfermedad por depósito de grasa, pero para realmente saber si tiene un hígado graso o una esteatohepatitis no alcohólica, es necesario hacer una biopsia hepática. Sería necesario hacer una biopsia hepática, porque realmente no hay manera. Como comentaba la doctora, uno tiene solamente grasa y leve inflamación o ballooning, y la esteatohepatitis tiene grasa más inflamación más ballooning, y son dos patologías distintas con pronóstico diferente. Así que si uno realmente quiere establecer un diagnóstico de certeza, tendría que ir a una biopsia. El tema es si uno necesita realmente establecer un diagnóstico de certeza o puede establecer un pronóstico sin hacer un diagnóstico de certeza, con otros elementos, porque la biopsia, como decíamos hoy, no le gusta a los pacientes, no está tan fácilmente disponible. Entonces, la respuesta es sí. Para hacer un diagnóstico de certeza no hay otra forma y discriminar entre las dos formas que hacer una biopsia. La otra duda que por ahí vamos a ver después es si realmente hay que hacerla en todos los pacientes o si se puede avanzar sin ella.
Doctora Cortés, ¿quiere agregar algo?
Bueno, esto es un caso típico. May I speak English for? This is a typical case that we often see in our clinical practice. What I think is that before, I completely agree that only liver biopsy could establish the diagnosis. But in clinical practice, I would first go through the serological methods. I would evaluate the NAFLD fibrosis score and the FIB4. And if it was easily available, as it is in my department, I would simultaneously do the fibroscan. At that point, I usually recommend, we have a team that has the dietitian, the psychologist, and so I try to put him during 6 months intensively doing that. And I could bet that if he really was able to lose weight, that the next time you'd come in 6 months, you'd have decreased the aminotransferases. So at that point, if he had decreased the aminotransferases and if the scores were all in the sense of a low probability of having advanced fibrosis, I would postpone liver biopsy. And I would not even consider putting him in a clinical trial, because if he has a very low NAFLD fibrosis score in FIB4, very probably you will not have significant fibrosis in the liver biopsy. So I'd either put him immediately on this weight loss intervention, or ask him, the FIB4 and the NAFLD fibrosis score, with the data you have, you could calculate it immediately. And as I saw that platelets were quite high, probably you will have a low FIB4. I don't know exactly for the NAFLD fibrosis score, but only in the second step, if the patient comes back, he still has elevated aminotransferases, the scores are high, he was not able to lose weight, then I would consider doing the liver biopsy. So I almost never do the liver biopsy immediately. I always give them 6 months of the weight loss interventions and having the scores before going to the liver biopsy. I don't know if you would agree with that.
Totally agree. Entonces, simplemente para la audiencia, para resumir, uno para establecer el diagnóstico de certeza debiera hacer una biopsia, pero tal vez en esta instancia no sería necesario. Uno puede establecer el riesgo del paciente, el pronóstico del paciente con scores, por ejemplo, FIB4 o NAFLD score, hacer un fibroscan también, digamos, en ese momento, o ver qué dan los scores y hacer un fibroscan, lo vamos a ver después, y evitar hacer una biopsia inicialmente, ponerlo al paciente en un régimen de dieta y ejercicio si el pronóstico o el riesgo es bajo y esperar a ver qué pasa con eso.
Muy bien, muchas gracias. Nosotros fuimos un poco más agresivos, realizamos la biopsia hepática, que lo que nos mostró fueron focos necroinflamatorios con valorización y fibrosis grado 1. El score de NAS fue 4, con 2 puntos para esteatosis, 1 punto para valorización y 1 punto para inflamación lobulillar. Entonces ya tenemos un paciente de 48 años con síndrome metabólico, con un NAS score de 4 y fibrosis grado 1. ¿Cómo determinamos el pronóstico entonces? Con características histológicas con las que ya contamos, el seguimiento con elastografía y o marcadores serológicos, factores de riesgo asociados que presenta el paciente como hipertensión, resistencia a la insulina, obesidad, la normalización de las transaminasas durante el seguimiento en caso que el paciente nos hiciese caso con las medidas higiénico-dietéticas o la combinación de todos estos puntos que les fui mencionando.
Bueno, ahora obviamente hecha la biopsia tenemos ya un factor pronóstico que está dentro de las características histológicas que uno ve en la biopsia, sobre todo, o yo diría casi exclusivamente, en el grado de fibrosis principalmente y mucho menos en el grado de inflamación. Pero también uno haría allí, digamos, otra vez con lo que tiene el paciente solicitado, uno puede establecer el NAFLD score y el FIT4 score, que vamos a ver, entiendo a continuación, y en base a eso también establecer un pronóstico, y uno puede, incluso teniendo la biopsia, hacer un fibroscan, que hay que hacerlo obviamente con una sonda especial para estos pacientes, y un programa especial, un software, y establecer un fibroscan de base, a lo mejor un valor de fibroscan para luego, al seguir al paciente, tal vez no tener que rebiopsiarlo y poder seguirlo con fibroscan y con scores serológicos, ¿sí?
De hablar español. Yo creo que todo lo que ha dicho está muy cierto. Por supuesto, tenemos la biopsia, por tanto, sabemos que tiene de facto un riesgo. Más la misma, yo intentaría lo hacer perder peso y ver qué pasa con las transaminasas después de todo ese programa de pérdida de peso. De cualquier forma, es obvio que tiene la histología como factor de pronóstico, los factores de riesgo asociado también, y por tanto, en el fondo es la combinación de los previos que nos dará el pronóstico, y la forma como va a progresar depende mucho de si es posible para él de perder peso o no. Eventualmente, este era un paciente que podría ser considerado para un clinical trial. Podría, mas yo nunca lo haría sin primero intentar de perder peso. Eso yo creo que es muy importante, no intentar por los pacientes en clinical trials, sin primero intentar lo que es más simple que la mudanza de estilo de vida.
Yo acuerdo con eso y no solamente en un paciente con fibrosis estadio 1, sino que el tema de la dieta y el ejercicio físico también me parece que es importante en pacientes con estadio 2 o 3 de fibrosis y no directamente considerarlos para un clinical trial.
Muy bien, entonces coincidimos que la combinación de todos estos factores nos van a ayudar a predecir el pronóstico de este paciente. Tan solo recordar, la doctora Cortés Pinto ya ahondó en esto en mucho más detalle, pero que tenemos criterios serológicos bastante baratos y fáciles de calcular que nos permiten valorizar la fibrosis y que son de utilidad en la
for the specialist or not. And that is not only for the general practitioner, but also for the other specialists. I think now we complain that we have few references. But in a certain point, it can also happen to the opposite, and that we are completely invaded by all the patients with NAFLD. So I think these rules, I don't know if you want to comment on that, Tom.
No, I mean, I think we also, we actually faced that in the discussions with the pharma industry, because they're coming to us now with all the trials that you mentioned, and they're asking us, so where are the patients? They actually have big recruitment problems, which they don't really know how to solve, and to really engage now GPs, diabetologists, where these patients actually are residing, and make an alliance as to case finding. I think it's a major topic which will have to evolve. Yeah.
Bueno, muy bien, avanzamos. El paciente se calculó su FIB-4, un grado leve de F0 a F1. El NAFLD score le dio un grado en la zona gris. Se realizó también una elastografía hepática con 6.1 kilopascales, también en concordancia con el FIB-4. Entonces, ya con toda esta información, ¿qué indicaciones le darían al paciente y con qué frecuencia controlarían esas indicaciones?
Muy bien, entonces vean el caso que finalmente el score le dio en la zona gris. Se hace el fibroscan y el fibroscan le dio un buen fibroscan, o sea, tiene un F1, o sea, es un paciente que está más del lado celeste de bajo riesgo que del lado gris o del lado rojo. Entonces, nosotros hubiéramos hecho lo mismo probablemente unos años atrás, pero hoy por hoy, como decía la doctora, uno tal vez podría en este paciente, antes de hacer una biopsia inicialmente, ponerlo en las indicaciones de dieta y actividad física, que no las voy a repetir en los detalles porque ya muy bien lo comentó Elena, la cantidad de actividad física está bien definida en las guías, la dieta también, y bueno, y solamente si eso fracasa, reevaluarlo, y si progresa, ahí, bueno, tener la posibilidad de ponerlo en alguna medicación, si es que existe, discutiremos ahora alguna medicación eficaz en el mercado o en un estudio.
Again, I agree with what has been said. So I would not start the patient at this point with any pharmacological therapy. The difficult issue is the frequency with which to see these patients. If I had not done the biopsy and I didn't have the information that he really had NASH, I could probably have sent him back to the general practitioner and say that he would come back in 2 years or something like that. But now that I know that he has NASH, although early NASH without fibrosis, I'd probably, at least in an early phase, see him each 6 months to see what happens with the lifestyle measure interventions. And also, somehow, I think it can be more, the patient feels he has a more serious disease if he's in a specialist. So keep him for some time. Because also we have to, what I said, even if it's not a fibrotic form of NASH, he still has a cardiovascular risk. So I think he should be kept on, and he should, at least I'd see him for in the next 6 months to check how he's going to progress, how he's progressing.
Muy bien. Entonces al paciente se le realizó un enfoque general, tratamiento del síndrome metabólico, se le ofreció o se le indicó el descenso de peso con actividad física y en este caso se inició vitamina E 800 miligramos por día. El paciente vuelve a control luego de 4 años, no solo no asistió a las consultas con nosotros, sino tampoco con su médico de cabecera. En la consulta se presenta ya con 4 kilos de peso superiores a su consulta inicial, incrementó su índice de masa corporal. La ecografía no mostraba grandes cambios, sino su ecogenicidad aumentada, compatible con estatosis. Se le vuelven a calcular los métodos no invasivos, el FIB-4 aumentó, ahora está en el rango de F2, F3, el NAFLD score se mantiene todavía en la zona gris y el paciente en este interín desarrolló diabetes. Entonces, ¿cómo evaluamos la efectividad terapéutica? Esto lo voy a pasar más rápido por una cuestión de tiempo. Idealmente sería disminuir la mortalidad general, incluyendo la enfermedad hepática y los eventos cardiovasculares, como hablaba la doctora Cortés. Los ensayos clínicos, lógicamente, no utilizan este tipo de valoración, ya que son a largo plazo y se necesitan, o ellos necesitan resultados más rápidos, y por lo tanto se utilizan criterios sustitutos para valorar los factores de riesgo de fibrosis y su progresión. Se realiza con estos valores una nueva biopsia hepática en la que podemos ver esteatosis grado 2, balonización grado 2, inflamación lobulillar grado 2. El NAS score en este momento es de 6, o sea, se incrementó 2 puntos con respecto a su biopsia basal 4 años atrás, y la fibrosis progresó a grado 2. Entonces, ¿cómo evaluamos el impacto de la fibrosis? Para ello contamos con los criterios sustitutos que les mencionaba. Uno, le gustaría que el paciente reduzca la fibrosis al menos 1 grado en el estadio. Podemos evaluar los factores de riesgo de progresión de la fibrosis con los criterios clínicos modificables, el descenso de peso, la hipertensión, la resistencia a la insulina o diabetes, y los criterios histológicos, idealmente resolución del NASH o reducción de 2 o más puntos del NAS score. ¿Qué opciones de tratamiento tenemos? Muchas de estas opciones han sido repasadas por la doctora Cortés, realizando en todos los pacientes con hígado graso dieta, tratamiento del síndrome metabólico en caso que tuviese algunas variables de riesgo, evitar la ingesta de alcohol, como ya fue mencionado. En pacientes con fibrosis establecida, acá es la duda, si debemos iniciar tratamiento farmacológico o no, y los pacientes con cirrosis tendrán el estándar de cuidado como cualquier otro paciente cirrótico. Entonces, yendo ya al final del caso, paciente con 52 años, con un síndrome metabólico ya establecido, con un NAS score que progresó a 6 y fibrosis grado 2, ¿con qué opciones farmacológicas podemos contar en este momento?
Sí. Como vemos, las opciones farmacológicas, este es un paciente para tratar, es un paciente de riesgo, es un paciente que progresó, en donde no funciona la dieta, no funciona la actividad física y las indicaciones. La metformina está bien para la insulinoresistencia. Como comentó la doctora Cortés, ni la vitamina E ni la pioglitazona han demostrado ser efectivas en la historia natural de la enfermedad, de modo que en este paciente habrá que esperar ya sea el resultado de estudios de fase 3, como el Regenerate con ácido beticólico, o los estudios de la Fibranor u otras, los que están ya próximos a salir, o directamente uno tiene la biopsia, el paciente es un grado de fibrosis F2, si tiene la oportunidad, ofrecerle el ingreso a algún estudio clínico de fase 2 o fase 3.
Yes, I also think that this patient is a patient that, if possible, could benefit for entering a clinical trial. I think we should not start at the moment. Obeticholic acid, it's not accepted for NASH, so although it's on the market, I've never used it besides from a clinical trial. And the other drugs, of course, pioglitazone depends on, also as the patient is diabetic, often we also have to rely on what is the opinion of the diabetologist, and we kind of talk with which is the preferred drug. But I think this is a patient who would benefit from a treatment at this point. In fact, also he was not able to lose weight, not to do any of the things. And the ideal would be to enter a clinical trial or eventually to try the pioglitazone, because also he has been doing the vitamin E without apparently any success. I must tell you that I usually do not use the vitamin E, but I think it's a possibility. I don't know if you want to comment on vitamin E. No. So that's it.
Maybe liraglutide would be an adequate job. Liraglutide might be.
Yes, that could be a possibility. Also, because we have not discussed this here, but some of these new drugs also make the patients lose weight, and liraglutide could have this beneficial effect of controlling better diabetes and simultaneously losing weight. Yeah.
You mean because he is diabetic,
also. But
because
not,
it's diabetic,
yes,
yes. At the present time, again, I think it's not acceptable, I think, to use these drugs that have been used in clinical trial. But if you had to choose a drug on the anti-diabetics, I think liraglutide could be a possibility.
Thank you very much.
Bueno,
Gracias, Manuel.
muchas gracias,
Gracias, doctor Garano.
Gracias. Okay, and then we move to the last block of this session. We have another case presentation by Sebastian Ramirez from Colombia.
Bueno, buenas tardes. Al comité organizador, muchas gracias por la invitación. A continuación voy a presentarles un caso clínico de interés. Yo creo que esa es la discusión de la doctora Alejandra.
Están un poco movidos los horarios porque venimos con un poco de demora. Es la anterior a esta.
Por cuestiones de tiempo trataré de hacerlo no tan extenso. Se trata de un caso clínico de una mujer de 34 años, colombiana, de la ciudad de Medellín, que se atendió hace 2 años por el servicio de hepatología. Es una paciente que venía con un cuadro clínico de varios meses de evolución, atendida inicialmente en el servicio de medicina general, posteriormente por dermatología, especialmente por prurito cutáneo, y sintomatología general dado por malestar general, y en ocasiones presentaba artralgias. Como antecedente, un hipotiroidismo en suplencia hormonal, no tenía antecedente de consumo de alcohol, ni tampoco tenía antecedente de consumo de medicamentos o sustancias hepatotóxicas. Y al examen físico, aparte de los estigmas de rascado crónico en la piel, realmente no habían hallazgos relevantes con un peso de 55 kilos. Esos son los laboratorios iniciales cuando consultó al servicio de hepatología. En amarillo vemos el límite superior de normalidad para el laboratorio de nuestra institución. Vemos cómo presentaba una elevación de las transaminasas hasta más de 5 veces, especialmente de predominio de la ALT, con hiperglobulinemia, además de marcadores de colestasis positivos, aproximadamente entre 4-5 veces el valor normal o el límite superior de normalidad, con una bilirrubina ligeramente aumentada a expensas de la directa. Se le tomaron los marcadores virales que fueron negativos, de una imagen de abdomen que no tenía cambios de hepatopatía crónica y una vía biliar completamente normal, y los marcadores de autoinmunidad con unos anticuerpos antinucleares positivos, uno en 160 con el patrón citoplasmático, unos anticuerpos antimitocondriales positivos, uno en 80, anticuerpos antimúsculo liso negativos y unos anticuerpos anticitoplasma del neutrófilo negativos. Ante esto es una paciente con una documentación de síntomas de colestasis, con una colestasis bioquímica documentada y unos anticuerpos antimitocondriales positivos que hacen sospechar, por la edad y por ser mujer, es una posible colangitis biliar primaria. Sin embargo, por los hallazgos de la hipertransaminasemia, la hiperglobulinemia, se consideró llevar una biopsia de hígado para considerar otros posibles diagnósticos diferenciales. Esta es la biopsia de hígado inicial, una biopsia percutánea, el 18 de marzo del 2016. Como ustedes ven, hay un gran ensanchamiento de los espacios porta, además de un gran infiltrado inflamatorio, especialmente dado por linfocitos y por plasmocitos, y con una destrucción de los conductos, algunos de ellos con tendencia a la formación de granulomas. Llamaba la atención que para la hipertransaminasemia que tenía la paciente no tenía una actividad lobulillar marcada y una actividad de interfase que realmente era leve. Otros hallazgos que se encontraron en la biopsia: una actividad lobulillar leve, una fibrosis hasta grado 2 y los estudios histoquímicos para enfermedades infecciosas fueron negativos. Este es el CD38, la paciente con unos plasmocitos aproximadamente de un 30 a un 35%, y además una citoqueratina 7 que se llamaba la atención, que presentaba una ductopenia del 50 a 60% de los conductos. Con lo anterior, claramente tenía una colestasis clínica, bioquímica, con marcadores de anticuerpos antimitocondriales positivos y con una lesión de conductos en histología, considerando muy posiblemente una colangitis biliar primaria, y por los hallazgos de la hipertransaminasemia y la elevación de los niveles de IgG sérica, se considera la paciente cursando con posiblemente un síndrome de superposición de hepatitis autoinmune con colangitis biliar primaria. Se inició tratamiento con ácido ursodesoxicólico, 15 miligramos por kilo por día, azatioprina y prednisolona. Esta es la evolución bioquímica del 2016. Se hizo un descenso gradual de la dosis de prednisolona y con un aumento gradual de la dosis de azatioprina y una dosis de ácido ursodesoxicólico estable, llamando la atención que para el 6º mes de tratamiento la paciente tenía casi una normalidad bioquímica y una mejoría sintomática importante. Sin embargo, en ese 6º mes la paciente presentó intolerancia al tratamiento con azatioprina, por lo cual como medicamento de segunda línea se inició el tratamiento con micofenolato. Esta es la evolución durante el 2017. Realmente después del año se empezaron a alterar nuevamente los marcadores bioquímicos, por lo cual se fue aumentando progresivamente la dosis de micofenolato hasta 2 gramos. Sin embargo, durante todo el año 2017 siguió empeorando bioquímicamente, vemos nuevamente hipertransaminasemia, vemos nuevamente con elevación de los marcadores de colestasis. En ese momento se suspendió el micofenolato y se trató de utilizar otro tratamiento de tercera línea como el tacrolimus y se indicó la realización de una biopsia o de una nueva biopsia hepática en la paciente. Esta es una biopsia laparoscópica que se le realizó en el mes 19 del tratamiento. Vemos nuevamente cómo hay ensanchamiento de los espacios porta, pero realmente comparado con el anterior no hay tanto cambio pues, en la fibrosis. Continúa el infiltrado inflamatorio, pero realmente en menor cantidad o magnitud comparado con la biopsia previa, y vemos cómo hay unas células inflamatorias especialmente dadas por linfocitos que tienden a formar folículos linfoides con una destrucción de los conductos y realmente sin una actividad de interfase importante. Lo importante aquí también es que la paciente persistía muy sintomática con una ductopenia que progresó hasta el 90%. Esta ha sido la evolución del 2018, realmente no ha sido buena, la paciente ha tenido un deterioro clínico y bioquímico importante. Como una opción que se consideró en el grupo de manejo, se hizo una combinación de tratamiento de 2 inmunosupresores. Sin embargo, la paciente continúa empeorándose. Para este mes tiene una bilirrubina que ya está en 5 con unos marcadores de colestatis de fosfatasa alcalina y gamma-glutamil que están por encima de 1000. Estas son las preguntas a discutir. ¿Consideran que existe alguna u otra alternativa diagnóstica? ¿Cuáles serían las metas de tratamiento y cómo evaluaría la respuesta terapéutica en caso de considerar un síndrome de sobreposición? ¿Y qué otras alternativas de tratamiento emplearía para esta paciente? Muchas gracias.
Bueno, muchas gracias, Sebastián. Claramente, evaluar pacientes con autoinmunidad no suele ser una cuestión demasiado sencilla, así que vamos a tratar de revisar algunos puntos que Sebastián desarrolló muy bien. Este es el resumen de la paciente. La verdad que es difícil no tener la posibilidad de señalar, pero bueno, ustedes pueden ver ahí que básicamente estamos con una paciente que, como él bien dijo, por su edad, por su sexo, por la presencia de prurito, por un patrón con predominio colestásico, con una inmunoserología con anticuerpo antimitocondrial, claramente es una paciente donde el primer diagnóstico presuntivo sería que estamos ante una colangitis, perdón el término cirrosis, estaríamos ante una colangitis biliar primaria. ¿Por qué? Porque básicamente el diagnóstico dentro del trípode conformado por un perfil y una colestasis clínica desde lo bioquímico y desde lo clínico de colestasis, un anticuerpo mitocondrial y alteración fluorida de los conductos, las guías claramente definen que con la presencia de 2 de estos factores, en nuestra paciente sería el perfil y la clínica de colestasis sumado al anticuerpo antimitocondrial sería suficiente para tener un diagnóstico probable de colangitis biliar primaria. Claramente, ¿por qué? Bueno, definitivamente porque el anticuerpo mitocondrial, como todos sabemos, es un anticuerpo de alta especificidad, raramente encontrable en el resto de las patologías inmunológicas con las que nos podemos enfrentar. Sumémosle un factor más, y es la presencia de, como él dijo, un factor antinuclear de patrón citoplasmático. Y esto es una ironía, porque el factor antinuclear se supone que no es citoplasmático, es nuclear, de ahí su nombre. Estos son pacientes a los cuales antes entendíamos como FAN negativos. Bueno, básicamente a partir de últimos consensos, las marcaciones inmunoserológicas citoplasmáticas se incorporaron al patrón global de FAN. Entonces hoy tenemos FAN nucleares, como haría honor a su nombre, y FANes citoplasmáticos. Y acá va un dato interesante. Dentro de los distintos patrones de FANes citoplasmáticos, tenemos que ser particularmente exigentes en pedir puntualmente qué tipo de patrón citoplasmático es el que tenemos. ¿Y por qué? Porque ustedes lo pueden ver señalado con asterisco, el patrón reticular, lineal y de dots discretos es altamente compatible también con CBP. Incluso el que indica la posibilidad de estar señalando actina, la actina la vinculamos a hepatitis autoinmune, sin embargo, estos factores antinucleares citoplasmáticos son más orientativos y reforzadores del mitocondrial positivo que de hacernos pensar en un contexto de autoinmunidad hepatocelular. Ahora, claramente, cuando tenemos estos elementos que nos hacen pensar en CBP, tenemos que pensar qué nos aleja de la CBP. Y como Sebastián bien dijo, nos aleja el hecho de que hay un laboratorio con transaminasas bastante significativamente elevadas y hay una inmunoglobulina sérica como marcador de activación inmunológica que nos da prácticamente por 1,5 veces el valor normal. ¿Qué nos hace pensar? Y si vemos elementos hepatocelulares sumados a los hechos, a lo que vimos desde el punto de vista de posibilidad de colangitis biliar primaria, claramente el diagnóstico de superposición aparece como una opción tentadora. Si vemos los criterios de París, que somos los que más comúnmente usamos en Latinoamérica y que exigen al menos 2 criterios de CBP y 2 criterios de hepatitis autoinmune, simultáneos o secuenciales en el tiempo, podríamos estar hablando de un síndrome de superposición. Vayamos a la paciente. En la paciente, claramente estamos encontrando algunos factores que inducen esto, pero lo que básicamente van a inducir sobre todo es la duda. Miremos críticamente los parámetros hepatocelulares. Las transaminasas están aumentadas, están rozando un nivel por 5. La inmunoglobulina G no alcanza el nivel umbral de ser por 2 o más. Pero bueno, démosle la duda y siendo que da 1.5, asumámosla como que puede ser orientadora de hepatocelular. Y tenemos ahí un marcador que no orienta hepatitis autoinmune por su contexto citoplasmático y un asma que es negativo. Indudablemente la discusión sería otra si el asma de esta paciente hubiera sido positivo. Ante este supuesto empate técnico, en la duda, pese a que la recomendación de las guías de la ISEL son de que la biopsia hepática no la necesitamos cuando existen claras evidencias de que estamos ante una CBP, el agregado eventual de algún dato que nos inclina hacia la hepatitis autoinmune nos pone en duda y nos lleva a biopsiarla. Del lado izquierdo de la diapositiva tienen los hallazgos de la paciente. Del otro lado tenemos los hallazgos característicos de la CBP, que cuáles son indudablemente mucha inflamación. La CBP es un evento de alta inflamación sobre los conductos biliares. Entonces es esperable que el espacio porta se encuentre bastante ensanchado eventualmente por células inflamatorias. ¿Cuál es el otro estigma? Indudablemente el daño concentrado en el conducto. Daño que puede ser inflamatorio, que puede ser de hacer desaparecer a los conductos, o que básicamente puede hacer incluso la formación de granulomas. Todos hallazgos que la paciente en cuestión indudablemente tenía. ¿Qué le exigimos a una paciente para decir estoy ante un componente hepatocelular predominante? Bueno, básicamente mucha inflamación. Inflamación que no le alcanza el límite del espacio portal, que se acumula en el borde del espacio portal y se escapa hacia el lobulillo a comerse a quién, a comerse al hepatocito. Claramente dos hallazgos que por las biopsias que acabamos de ver no estábamos viendo. Tampoco veíamos cambios lobulares significativos, ni veíamos en peripolesis, ni ninguno de los datos que indudablemente nos harían pensar que estamos ante un componente hepatocelular asociado. Lo que sí tenía era, como él mostró, una actividad importante en la zona limítrofe entre el espacio portal y la entrada hacia el componente sinusoidal. O sea, había un área limítrofe donde indudablemente diríamos que tenía algo de hepatitis interfase. Ahora, la pregunta del millón, que los grupos más importantes que han estudiado esto no terminaron de definir nunca, es cuánta hepatitis de interfase tenemos que tener para que podamos decir esto es hepatitis autoinmune o esto es solo una CVP con mucha inflamación portal. Bueno, indudablemente necesitamos bastante más de la que esta paciente nos está mostrando en la biopsia. Entonces, si tenemos dudas, ¿qué podemos buscar? Cuando hay duda en hepatitis autoinmune, uno, ¿qué va a buscar? Cuando no le alcanzaron los criterios simplificados, va y busca el famoso score de hepatitis autoinmune atípica diseñado por el grupo de hepatitis autoinmune. Si lo aplicamos, básicamente, créanme, hice la cuenta, el score de tratamiento da negativo. No es que se acerca, que sí es probable, directamente da negativo. Y esto también es un aprendizaje. ¿Y por qué es? Porque cuando uno está queriendo evaluar superposición, la aplicación del score diagnóstico no debe ser aplicada, ya que claramente es un score que penaliza absolutamente la colestasis. Y en esta paciente tan colestásica la penalizó tanto que la paciente terminó dando saldo negativo. La verdad que se parece mucho a una colangitis biliar primaria. Ahora, claramente no parece una colangitis biliar primaria común y silvestre, sino que parecemos estar viendo una forma particularmente ductopénica. Y es una forma dentro del contexto general donde la característica mayor es que hay una desproporción absoluta entre el desarrollo de ductopenia y fibrosis. ¿Qué quiere decir esto? Toda la CVP es ductopenizante. Pero uno en una CVP clásica llega a la ductopenia después de que fue desarrollando fibrosis y la propia fibrosis colaboró con la inflamación en comerse los conductos y hacerlos desaparecer. Hay reportes de la variante ductopénica sin fibrosis, claramente, son reportes antiguos, pero hemos asumido que estos cuadros existen, afecta sobre todo a mujeres jóvenes. Cuando se publicaron estos estudios en el 2001 todavía sabíamos poco de FAN citoplasmático, pero ya se veía que había una alta frecuencia de FAN positivo, lo cual probablemente era una forma de este tipo. Desarrollo acelerado de fibrosis, pero no como evento inicial, sino una vez que los ductos desaparecieron y generó progresivamente una carga de desaparición ductal. Da mucha colestasis, el cuadro de esta paciente, cada vez empeoraba más su prurito pese a todos los intentos y falta de respuesta al tratamiento. La evolución, él la resumió, poca mejoría bioquímica para haberle utilizado no solo el UTCA, sino también inmunosupresores, y esto nos hace pensar y de nuevo volver a las guías y decir, ¿la paciente tenía factores de mal pronóstico? Según lo que establecen las guías y la experiencia, claramente sí. Empezó en una edad temprana, desarrolló ductopenia temprana, no respondió al tratamiento suficientemente, así que claramente el hallazgo de la nueva biopsia, tal cual describió Sebastián, era un poco lo esperable. La ductopenia se había profundizado, el infiltrado periductal se mantenía, o sea, lo que quedaba de conductos todavía era agredido, había colestasis citoplasmática, había fibrosis todavía grado 1 para la severidad de enfermedad y la manifestación bioquímica. La verdad que, Sebastián, en tu presentación me contestaste la duda mayor que me planteaba el caso, que era cómo una paciente que se está comiendo conductos a esta velocidad, porque todo pasó en 18 meses, valoremos ese punto, cómo había tenido capacidad de mejorar su bili, que había sido 1,64 y ahora claramente era normal hasta donde vos llegaste. Bueno, vos ahora dijiste que meses después ya tiene niveles de bilirrubina, como eran esperables, cercanos a 5. ¿Qué debiéramos haber hecho? La verdad es que las guías no especifican qué pasa con estas formas tan agresivas de CBP. La verdad que uno las engloba dentro del total y asume que básicamente, bueno, si no hay posibilidades de respuesta adecuada, debiéramos agregarle segundas drogas. Hoy, tal cual planteó el doctor Carlsen, las segundas opciones pueden ser el obeticólico y el bezafibrato. Uno se pregunta, ¿hay experiencia de estas drogas en este subtipo particular? No, pero la experiencia que tiene uno, más que nada cuando uno está incluyendo, hoy como nosotros que estamos incluyendo pacientes dentro de los trials de obeticólico, uno entiende que dentro de ese universo hay pacientes con esta forma que no respondieron a la medicación con UTCA exclusivamente, más menos el agregado de inmunosupresión, y que son los que vamos a ver en el transcurso del tiempo si realmente sacan algún beneficio de estas drogas nuevas. En conclusión, a mi entender, no tenemos elementos suficientes para avalar un diagnóstico de síndrome de superposición ni antes ni después de haber visto la respuesta al tratamiento inmunosupresor. Entiendo que se trataría de una variante ductopénica temprana de colangitis biliar primaria, una forma que por suerte vemos poco, pero que cuando esta demuestra tal severidad, que más allá de lo que uno pueda ensayar de medicación, uno debe tener en mente que su opción definitiva probablemente sea trasplantarla. Muchas gracias. Tom, any comment?
I have very little to add to your beautiful summary. I totally agree with you. I was also observing the case and the development and how you were building along this axis of immunosuppression. I mean, we clearly see these patients. They come there like, you know, we have 1 or 2 every year that behave like this. Typically the young patients, young women like that. And what you're observing here is probably that the inflammatory aspects that you actually do observe, they're driven by pathophysiology, which is related to the PBC. And it's not really autoimmune hepatitis. So once you're sort of hitting the wall with your immunosuppressive avenue, you actually have to step back and go the other one. So I totally agree. It's a perfect summary.
Thank you. You will be talking about overlap syndrome.
Yeah, we will mention these patients tomorrow. I mean, there are, and clearly these non-responders should make you actually, in some instances, step back from your immunosuppression and stay with your cholestatic diagnosis, which this patient clearly also did. Yeah.
Helena,
can I ask just? You all agreed that in the beginning you would have started immunosuppression. It's just the development of the case that clearly indicates that it's not an overlap syndrome. Okay.
That's it. Sebastián, ¿querés decir algo? Okay. Well, bueno, gracias a todos ustedes. Thank you very much, Helena and Tom, for taking part of this meeting. And bueno, nos seguimos viendo eventualmente mañana, que siguen los temas de autoinmunidad para los que están interesados. Muchas gracias a todos.